to the Stronger After Stroke podcast. We are here today to talk about intimacy and sex after stroke. And as we talked about in our previous episode, intimacy does not necessarily mean sex, but sex often is a very important part of intimacy with your partner. And that can change a lot after a stroke. So we're here with Lindsey Adler. She's a physical therapist and a pelvic floor specialist.
Yeah.
Is that the best way to describe it?
Specialist, yeah.
And lymphedema.
It's okay.
And then we have Michelle Stillwagon. She is a licensed family and marriage and family therapist. Thank you. And certified sex therapist, which is why you're here. So, so we want to talk about the communication that affects intimacy in mild and moderate cases. What are some physical barriers and what are some tips to manage some physical barriers?
So on our side of things, the most common thing that we would see in a pelvic floor setting relating to stroke would be hypertonicity, which means my muscles are tighter. There's something called spasticity, where if I move really fast, it spasms back. And it can be affected in so many ways, including, unfortunately, arousal. You know, we can get more tone, more hypertonicity with more arousal, with orgasm. And
so more tension with more arousal.
Yes.
So you're feeling good, but feeling tight.
But also like, oh, this might turn into a spastic episode where I have a lot of tension, cramping, like a Charlie horse.
And pain.
And pain. It doesn't feel good. So you can have that anywhere in where you're affected, meaning pelvic floor. It's the same kind of muscle. The pelvic floor just sits like a hammock in the bottom of your pelvis, and it squeezes and it relaxes. And Kegels, everybody knows the Kegel squeeze, I feel. Men can do them too.
They might not have known that.
I know. A lot of
you can, men.
You can.
And you should.
You can do it. The cue for women, the cue for women we like to use is try to pick up imagine you're trying to pick up a blueberry with your vagina or cutting off a stream of urine. We use very odd cues. And for men, sometimes we say, try to imagine you're sitting on a cold toilet seat or you're trying to retract your testicles and they can find their pelvic floor a little better. You shouldn't see any movement from the outside. When this happens, it's all a stabilizer. That's why it's hard to train. So anyway, so they can become spastic, tight, and my biggest tips for this is to manage your tone throughout the day. Global tone, not just pelvic floor. Do your tone reducing postures. Tone can present in several ways. You can be tight this way, you can be tight this way. But either way, breathing exercises, consistent stretching, ice or heat can be helpful, really. Heat improves blood flow. The ice can reduce the neural hyperactivity that's relating to tone. So I tell people to play around with it. Play around with times of day that you're intimate. Side lying, make sure you're supported if you're the male or the female. Try to get into a position where you can be supported and in
like
a relaxed
physically
state.
with pillows?
With pillows or
If
wedges.
If you take a medication to manage your spasticity, try to plan intercourse around an hour after, so it's kind of at its peak functioning ability in your system. And those are just tips that we use. You know, rotation, rocking side to side, rhythmic things, and just meditation, relaxation techniques for the physical.
And it strikes me that thinking about some of those things that you were talking about, even like the heating pad, using some ice, doing some relaxation or tensing and releasing, might be things that you and your partner could do together. A little massaging, kind of relaxing into whatever kind of play date you're having together, you know, but also participating. So if there isn't an expansion to another level of arousal or to taking clothes off even, there still can be that intimate touch, that closeness, and it also may bring the fear and the anxiety about what it's going to be like for us to connect again, you know, and differently. It may bring that down a little bit just to know we can have this kind of touch.
Right.
You can rub my shoulders. You can do a little hair massage because that tickles and feels good. Or maybe I I don't like that anymore. There's a different erogenous zone that I have now. The body and the brain is so fascinating, the way it can move things around, so that if one piece of, what you're used to functioning in a certain way shifts, then maybe you have an erogenous zone now in the elbow or under your knee.
That's a different kind of funny bone.
Right? It is. Yes.
I've not heard of that one yet.
And we talk about like touch without expectation, like just helping
expectation.
Yes,
that's what I call it.
Touch without expectation.
And then that way your body kind of tells you what you like again without an expectation of anything. And you don't have to think about, am I going to have to do this? Am I going to have to do this? It's more just like, we're just going to touch. We're going to spend time touching. So I like
But how cool if that can also relax the tone, keep you moving, doing stretching together, even some assisted stretching. Maybe you could ask someone like Lindsey, how can I help my partner do some of these stretches and feel part of that? And maybe that would also help you feel more comfortable with each other's bodies and with asking for help, because again, that communication piece is so important, and the team building piece is so important for having just intimacy and close connection and ways to communicate and learning each other's ways to communicate. And
we very often do partner training in pelvic floor therapy, and it is completely non-sexual touch, obviously. And
in the office.
In the office, sorry, in the office. At home, you can do whatever it feels natural to you. But in the office, we talk a lot about like, this is our prep work to get to intercourse. And sometimes it'll be more of like a desensitization protocol. Sometimes it'll be a stretching protocol. And I always invite the partner to come and to participate to whatever level they are wanting to. And so we've done that so many times, and it's so helpful. Of course, it's always with the primary patient's consent if they want them there. Sometimes, we work up to that. And it's nice when people are open, because there are so many opportunities that are missed because of fear, I guess, or taboo, or I'm going to ask a weird question or something like that. So
it doesn't necessarily fall under the list of like, well, this is a stroke-related thing, or this is a marriage-related thing. But even if you go to like marriage talk therapy, that's not necessarily a place people always think about. Let's talk about the mechanics or the practical steps to having a good sexual relationship, right? So would you say, Michelle, as our resident expert?
Yes, definitely. I think when I was doing marriage and family therapy prior to my certification as a sex therapist, I felt like a plumber who couldn't fix a toilet. Like there was often.
That sounds so helpless.
I mean, there often with couples was that question, and I didn't know enough. So that's why I actually did the certification to become a sex therapist and to become an expert in that area, because it is part of coupling. It is part of, the language. So much of our languaging and love languaging especially is body language. And so when you're learning your body anew, but you're, older and used to certain things, or, older than a baby anyway, who's learning everything new, right? There can also be some concerns like, am I going to be able to hold my bladder? Or do I need to do a different kind of cleanup before we get into bed, or we are able to be cozy with each other? Maybe I'm really aware of that, and so I want to make sure that I've, rinsed off or brushed my teeth or whatever it might be, right? And that's a really normal piece of things. But I think when you've had an event like a stroke, it becomes something almost like bigger in your head than thinking about, no, I need to use lubricant and that's just okay. Or no, I need to brush my teeth and wash my face and that's okay.
And it's not a personal insult to your partner like, oh, you're experiencing dryness, I guess that means you don't like me anymore. Right. Be an inaccurate conclusion.
Absolutely.
Right?
Yeah, because the body has
something to discuss and just be like, this is just a tool I need to use now.
Well, and mind and body connection is so important too. If your mind and body are not connecting well, it may take, responsive drive. You may not feel like you have a sex drive anymore, and that's really common. I think a lot of people kind of lose their sense of desire or drive initially because everything can be so overwhelming after an event like stroke. Being able to maybe say, we'll see, and let's see what happens. Again, no expectation. We don't have to go to level XYZ. We can stop wherever we need to. And I'm not going to take it personally if we need to stop. I'm not going to assume that means something about me or that we're never going to have sex. We're not going to catastrophize it, right?
Yeah,
right.
We're going to do little steps, but to feel more confident, to feel more comfortable, and to get the mind and body a chance to connect. Because if you're in your head and you can't get in your body, you're not going to enjoy it as much as if you're in your body and able to kind of release all the fears and depressions and anxieties and things that are taking up, or task-oriented things that take up so much of your time.
Yeah, and go ahead.
Well, I was just going to say that a lot of people are more self-conscious about incontinence that happens after stroke, which is just a part of it sometimes.
Yeah.
It could be fecal or it could be urinary incontinence. You may have a partner who does not care.
Right, absolutely.
But the person who's bashful about it may not want to have that conversation. And so it's going to be very important to have that conversation, even though that itself is uncomfortable. I really want to encourage people to just talk about it and say, is this something that bothers you? Do I need to have that cleanup when you're not around? Or is this just not an issue for you? And if so, then that can help you get out of your head, like you're talking about.
Yeah.
But I think, Lindsey, before we got started, you had a great analogy. Is that where you were
that's
going?
what we're going to talk about. Is sometimes, like I think we talked about in the first episode, you get put into a bucket of your diagnosis. Like now everything is related to my stroke. Everything that's happened after the stroke is because of the stroke, or because I have MS, or because whatever it is. But sometimes we'll have several things leading up that are increasing your risk to have leakage. I had vaginal births. I had the prostate surgery. I have latent weakness. I haven't had any kids, but I have weakness. You don't have to have a birth or surgery to have pelvic floor dysfunction. Some people just have it. In the same way, some people have a wonky knee that bothers them, So basically, and the other thing, the concern would be for hygiene, for intimacy, for infection risk. We want to decrease risk for infection. There are things that we can do in pelvic floor therapy. And just because there was a stroke involved doesn't mean this wouldn't have happened without a stroke. Maybe it would have happened just a couple years later. And there are things we can do. There are exercises, there are stretches, there are habit changes and ability, strategies to empty your bladder more completely. There are medications that can help. A big thing, the analogy that we talk about is if you're just treating that symptom that presented, if we're like, it's the stroke, I'm going to give you more baclofen, or, that's just the way it is now, that part of the brain is damaged. It's kind of like you're just mopping the kitchen floor while the sink is overflowing. You can't just treat, and I talk a lot about this in the context of pain. You can't just treat the physical, we have to treat the emotional. And then also, what's the reason why I'm compensating this way? What's the reason why I'm leaking? It's not just the stroke, but it's the stroke, the scar from my C-section, latent weakness, I've been inactive. There are things we can do. So please, please, please reach out. Sometimes people only leak with orgasm. Sometimes people only leak with arousal. That's something that can be helped, and we definitely don't want you to have an increased infection risk. So please reach out, and we hear it a lot, and we just want to help. So
because you need somebody to really ask those questions, just like I need to know the context of what's going on in the relationship in order to know how to help. The more information we have, the better we can serve you and your partner, and make sure that you're getting all of the things that you need to feel, healthy and well, but also to feel like you can experiment, to feel like you can try some things without there being a risk, right?
Absolutely. And it's just comfortability with the provider too, right? Like, the doctors don't have a lot of time with people. And so sometimes it kind of feels a little bit regimented, and we're going to make sure everything's going. And that's unfortunately just the way it is with time constraints. But you can always bring that up. But if say, someone says, are you having any issues with leakage? And maybe someone's embarrassed. Like, I don't want to talk about that right now. So I'm going to say no. I know the answer is yes, but I'm going to say no. And then that question's not asked again, because we think it's not an issue. So please don't be afraid to bring it up. And please don't be afraid to bring it up 5 years after the stroke.
If you have something like MyChart, which is our electronic health record that lets you communicate with your doctors, and you're like, why didn't I tell them that in my appointment? You can send them a MyChart message and say, actually, this is an issue that I didn't talk to you about, so can we address this? And you can ask for a referral to a physical therapist. You can ask for a referral to a talk therapist, and they can connect you with local resources.
Or a support group, which can be really, really great to be around other folks who are speaking the same language as you, having similar issues, and you find a community there, not just, of support and also of sharing ideas about what we tried and what worked well for us. And there's probably less of a need or a feeling of like taboo or that kind of thing when you're talking to other folks who really have that in common. Just like a depression group, would be people that have depression in common, or post-divorce would be people that have, that in common. It's really no different, but the community building and communicating those needs and those fears and those, worries is really important to build a place that you can do that, not only within your partnership, but to have a larger social support so that it's not all you and your partner, or all on your partner to respond, or all on you to ask for everything from a partner. You can hear about other things that people are doing, right?
Yes.
And there's so many like foundation websites and things online. Like I know there are a couple of self-led courses that I kind of guide people toward it. I'd love to hear your perspective on this as a sex counselor. I know Vanessa and Xander Marin they used to have a self-led course called Finishing School, and it was just like how to basically orgasm on your own and then orgasm with a partner. And it's something that
and it sounds so classy.
It is. It's kind of like I, got my little tea, lunch tea,
Oh, yes, it does.
Yes. But
Literal cotillion.
Yes, exactly. That's a great word.
Wow, I've always wondered what they taught at cotillions.
I know. But it's not what you thought. But they no longer offer that specific course, but they have on their website, it says like we are creating new courses, and there's also a website called OMG Yes. And so it's like just if you want to investigate it on your own, I always encourage people to investigate and like get confidence in yourself first, and then if and when you get stuck, Michelle's here and Lindsey's here and our doctors are here. We're here to back you up. But that's a great way, like a place to start and just educate yourself, because when we know more about it, we're less afraid of it,
True.
So,
definitely. And if you are looking for a stroke survivor support group, I lead one monthly, and it is virtual as well as in person. I have a virtual one that's separate from in person. I'd love to have you join us. So follow on our Facebook page at the Norton Neuroscience Institute, and we'd be happy to have you. Thank you to both of our guests for coming and investing your time in teaching people beyond who are just your patients.
Yes, and have fun, enjoy, be seeking for yourself always what you want, what you and your partner want, and don't feel like you have to have restrictions to your fun,
And don't push through pain.
There you go. If it's painful, stop.
If it's painful, stop.
Yeah.
All right, and we'll see you in the next episode of the Stronger After Stroke podcast.
Yep. Thank you.
Thank you.